Okay, good morning, everybody. We're going to get started. We may have some colleagues joining us as everyone gets settled in. Thank you so much for joining us for our Student Support Series, Professional Learning for Youth Mental and Behavioral Health. Today's topic is Insights into our Youth Mental Health Landscape. So for those of you who don't know me, my name is Kate Bohannon. I'm an Associate Education Consultant for the State Department of Education. A couple quick housekeeping pieces before we get into our presentation. So your cameras and microphones are disabled, but please use the chat or the Q&A function. The chat seems to be a little more user-friendly. That's what folks used predominantly last time. This webinar is being recorded, and the recording and slides will be shared with all registrants. So you should have gotten the PDF copy of the slides this morning. I do want to point out that those slides are not accessible for assistive technology such as screen readers. When these slides are posted later on, those will be accessible. It may take a little bit to get those slides up because it is a bit of a process to make sure that everything is accessible. Confidentiality. Please be mindful of sharing identifying information about your students. We want you to be able to speak openly about your experiences or your thoughts, but again, we do have a lot of folks here, so we want to make sure we're respecting the confidentiality of our students. And if you're having technical issues during the presentation, please email me. It may take me a minute to get back to you as I am kind of doing a couple different duties here, hosting and tech support, but I'll get you in or hopefully get that issue resolved as soon as possible. So moving on, this webinar has been approved for 1.5 continuing education credit hours by the National Association of Social Workers, and it meets the continuing education criteria for Connecticut social work licensure renewal. It is also valid for LMSWs, LMFTs, LPCs, and licensed psychologists. Beyond that, you need to talk to your accrediting body to see if they would accept these CECs. If you do find that out, please feel free to email me and I will be happy to get you that certificate. You can see quick below the criteria to receive free CECs. This is only available for an employee of a public school district. That's inclusive charters, magnets, and our CTEC schools, a private school, special ed, or alternative education program. Our colleagues from the community organizations are more than welcome to join us, but at this time we're not able to offer those free CECs. At the end of this presentation, there will be a QR code for a CEC request form. Please make sure that you fill that out and make sure you fill it out accurately. As I was processing last webinar's requests, there were some folks whose email addresses weren't entered correctly, so they got bounced back to me. So to make sure that you get your certificates, make sure that's all accurate. That request form is going to be open for 2 weeks. It closes on Halloween, October 31st. We are using an automated process to send out those certificates. So after the 31st, the form will close. If you miss that window, please email me and I will see about getting you the request form and the certificate, but please understand that may take longer. All right, moving into our agenda. You all know who I am. Next, we will have Adora Harisi. Did I do it okay? Yes, okay. She's an epidemiologist from the Department of Public Health, and she'll be talking about our Connecticut School Health Survey. Next, we'll have Stephanie Bozak, who's a behavior program manager for DCF. She's going to give us some information about the mobile crisis and urgent crisis center utilization. Dr. Stephanie Bozak is also my partner in crime and behind this brainchild of the Student Support Series. So she wasn't able to join us last webinar, but you will be seeing and hearing from her moving forward, hopefully. And then finally, we will have Angela Corsino. She's sharing information about the Connecticut Clearinghouse, which is a wonderful free resource for everyone in Connecticut. So you'll get some new tools and some exciting information. Before we jump into the meat of our presentation, I did want to just do a quick overview of Connecticut's education landscape. I think it's always good to ground this work and this conversation in who our students are and who we are. So you can see this is for the 2004-2005 school year. Hopefully we'll have oh, no, this is the updated information. I'm sorry, I forgot what year it was. So this is last year's data. You can see the number of students that we have, 54.9% students of color, 44.8% of students in Connecticut are eligible for free and reduced price meals, 11.8% with disabilities, and 11.3% English learners. Some quick information about how many school districts we have. And then on the right here, some interesting information about our mental health staff. 7,058.1 full-time equivalent mental health staff positions. You can see the numbers for certified school social workers, psychologists, counselors, nurses, BCBAs, and our certified marriage and family therapists. So I think that's just, as we're talking about this data, as I said, it's good to ground it in who our students are and who we are as a reminder of what we're doing and the larger community that we're all part of. So now I am going to pass it off to Adora.
Right, thank you so much, Kate. We can go to the next slide. All right, so the Connecticut School Health Survey, or is known nationally as the Youth Risk Behavior Survey, is a school-based survey that is done in collaboration with Connecticut and CDC. So as I mentioned, in Connecticut, it's only done with high school students, grades 9 through 12, and it's conducted every other year since about 2005. We actually just completed our 2025 survey this spring. It's always done in the spring semester. The survey itself, it's about a total of 99 questions, so it takes about 25 to 30 minutes. And the question is composed of sort of two parts when we formulate the questionnaire each year. We have to keep about 2/3 of the questions have to come from the CDC standard questions form. So every year before the survey starts, we get a CDC standard questionnaire with the questions that are vetted and proven by CDC. And we have to keep 2/3, so about 66 questions. And then the rest of the questions can be a mix of state added questions, a standard CDC standard questions, or optional questions. So the states have the freedom to create whatever questions they require. The way that it works in Connecticut, actually, we work together with other departments of the Connecticut Department of Public Health, along with the Department of Education and other state agencies to create this questionnaire. So it's not just done by my program alone, because each, other programs know better what is needed, the kind of questions that need to be asked. There's the kind of questions that are asked at the survey. It's a mixture. There's different topics. It really ranges from injury to violence to healthy eating habits to adverse child experiences, substance abuse, you name it. We probably have asked that question. And it's really used to monitor health risk behavior and protective factors among youth. It's really important. I know a lot of schools that have used the data to track their progress towards meeting the school's health goals or health promotion. And in the legislative body, it's actually used to push for new legislation and new policies. Next slide, please. So how are schools, we get this question quite a bit, so I just wanted to throw it out there. So how are schools selected for the YRBS or the Connecticut School Health Survey? So Connecticut will provide CDC a list of all the schools, the public schools, charter, alternative, tech schools in Connecticut that have grades 9 through 12. And the data also includes enrollment count, the percent of free and reduced lunch, their suburban, rural, city classification, poverty levels, low, medium, and high. And actually, all this data is available at EdSite, so I'm very thankful for EdSite because it just makes the process so much easier. Once CDC received the list of all the schools, they build what is called the sampling frame. So the goal for CDC is that they create a sampling frame that is representative of the schools by region, urban and rural location, and size. So for Connecticut, because it's fairly stable in terms of like enrollment size, it's about 50 schools per survey year, which revolves around 4,000 students. Once CDC creates a sampling frame, they send it back to the state. And then the state, we work with a vendor who's fabulous, and they reach out to the schools on that sampling frame. And they set up the administration date, they pick out the classes. So each school will actually have a specific class that's selected for the survey participation. So it depends on the enrollment and the class size. And then all students that are selected are asked to take part. We have a opt-out process, meaning that unless we get explicitly told by the parent that their child cannot participate in the survey, all students can participate. So this actually worked out really well. I know some states have the opt-in process and it's very cumbersome for them, but we're very thankful that we have opted for the opt-out process. Next slide, please. So just a little bit of history of the YRBS, or the Connecticut School Health Service. We're trying to rebrand it to the Connecticut School Health Service, and I'll fill you in a little later why. But it has a long history, and it dates as far back as 1997. But in Connecticut, it was successfully implemented in 2005, where we had really good participation rates. And throughout the years, from 2005 till 2021, we actually, the old coordinator, I'm relatively new to the role, but the old coordinator really faced challenges in getting schools to participate in the survey because it was mandatory. But thankfully, she worked really hard with the legislative, and she was able to pass the Public Act 22-87, which requires that all schools selected in the YRBS or the CSH survey are required to participate. That really helped us when we did the 2023 survey because we actually had 100% school participation rates. And that really does help us get a very representative sample of the schools in Connecticut, so we get a really good landscape. Again, on the side, I included some of the topics that I mentioned are in the survey, so you'll see it's not one specific topic. So depending on what you're interested in, you could probably find a question that we have asked. Next slide, please. So just as I mentioned, the 2025 survey we just completed. So the data is sent to CDC for processing and cleaning up and for quality assurance. So the state will receive that data probably mid in 2026. So we're just working with the 2023 data, but that's still very relevant and still timely as well. So next slide, we'll talk a little bit about the demographic and what it looked like in 2023. So as I mentioned, the school rate response was 100%. And the student response rate was 76%, which is perfect. CDC usually has a threshold for us of around 68%, so we exceeded the threshold, and that's around 3,100 students. The gender distribution was 49.1% male and 50.9% female, so fairly even. Next slide, please. In terms of the grade distribution, again, they tried to get a very even and representative distribution. So 27% of students that participated were in the 9th grade, 26% in the 10th grade, 24% in the 11th grade, and 23% in the 12th grade. Next. In terms of the demographics of race and ethnicity, I would like to say it's fairly representative of the state of Connecticut, to be completely honest. So 5% Asian, 13% Black, 29% Hispanic and Latino, 49% white, and 4% multiple races. So we do try in that sampling frame that CDC tries to get a representative of the student demographic for the state. Next slide, please. So this is what it looked like in terms of who answered the survey and who participated. I want to talk a little bit about some of the highlights and trends as it relates to youth mental health. So if you go to the next slide, we ask a question always, and I think it's one of the first questions in terms of general health. So the question is the percentage of high school students who describe their health in general as excellent or very good, and it's stratified by sex, grade, and race and ethnicity. So about 55.6% of students said that their general health is excellent or very good. And when we look at that broken down by sex, we notice that male responded to 63.2% of their health being excellent or very good versus females at 48.7%. I do want to point out that if you look at the bottom of the screen and when you get the slide, I have pointed out when it's statistically significant. So we have when it means that the difference that we have observed between the two, it was actually unlikely to have occurred by random chance. So there's something there. So when we compared male to female, it was statistically significant. When we look at the grade distribution, there really was no statistical significance. It was fairly evenly distributed. It ranged between 54 to 56%. And then when we look at race and ethnicity, that's when we also notice another statistical significant and a difference in the responses. So about 60.1% of white students claimed that their general health was excellent or very good. Asians were at 58%, Black students at 54.9, and Hispanic Latino at 46.9. And when we compare white students versus for statistical significance with Hispanic and Latino, and that difference was statistically significant. Next slide, please. This has been a question that we have asked consistently since 2005, and it's been, for the past 10 cycles, and it's been fairly, actually, there was no change from 2005 to 2009, and then we started noticing a decrease from 2009 to 2023, and we really started noticing a dip in their overall, their description of their overall health in 2021, which was, it went from 57.3 in 2019 to 53.7 in 2021, and this is post pandemic. So this was the first survey that was done after the pandemic. But the past 2 years have been relatively stable. Next slide, please. The next part is we ask a lot of questions. We ask four main questions on mental health and suicide ideation. If you could go to the next slide, please, Kate, thank you. The first question that we ask is for students to report their mental health and how it was in terms of the past 30 days. And then we have made into a category, but it's different days where the mental health was not good. But overall, the question that we're presenting today was, how was your mental health, and how, if your mental health was most of the time or always not good. So about 27.8% of students said that their mental health was most of the time or always not good. And female reported at 38.1%, which was higher than their male counterpart at 16.7%, which was also statistically significant. There is no difference among the grade group. It's fairly even, as I mentioned, 26 to ranges from 26 to 28%. But we do notice that statistical significance again when we break it down by different race and ethnicity, with Hispanic and white students having higher rates of most or not always good mental health at 29%, and that percentage decreasing with Asian and Black students. Again, that's statistical significant. You can look at the bottom for each group because they compared, but both Hispanic and white are statistically significant when compared with their Asian and Black counterparts. Next slide, please. This is a fairly new question. It was asked for the first time in 2021, and students reported at 28.5% of them not having good mental health. And fairly, there's been no change from 21 to 23, so there's not much to really say about. This is a question that we're probably going to keep moving forward because we do want to collect more data so we can look at the trend. I personally wish we asked this question pre-pandemic because it would have been interesting to notice how that trend changed, because anecdotally we hear that really had affected youth mental health. So next slide, please, Kate. The next question that we ask is for students to rate if they have ever felt sad or hopeless, and it's almost every day for more than 2 weeks in a row, so they've stopped doing normal activities ever during their 12 months prior to the survey. So about 35.2% of students said that they felt sad and hopeless, with that difference really being noticeable among gender. So 46.5% of females said that they felt sad or hopeless versus 23% male. And again, that was statistically significant. You'll notice that there's a lot of statistical significance as we move forward the slide in terms of sex when we break them down. There's not much. Oh, can you go back? It's okay. Thank you so much. No, it's okay. There is also statistical significance when we look at the grades. So 11th and 12th grade had higher rates of them reporting that they felt sad or hopeless versus the 9th to 12th grade. And then that difference is really noticeable when you break it down by race and ethnicity, with 40.6% of Hispanic and Latinos reporting they felt sad or hopeless in the past 12 months, followed with an even split between Black and Latino, Black and white students, and the last Asian with 22.3%. And when we compared Hispanic students with Asian, Black, and white students, that difference in responses was statistically significant. Next slide, please. This question has been asked consistently, which I'm very happy that we have this kind of data. And we have actually noticed that there has been an increase overall from 2005 to 2023. But really, if you focus on 2017 to 2023, you will notice that difference. And the biggest jump that we noticed was from 2019 to 2021, where it went from 30% to 35% of students who felt sad and hopeless. And then it's fairly stabilized between 2021 and 2023. Next. The next question that we ask in terms of mental health is about suicide ideation. So there's a question about if students have seriously considered attempting suicide. So 15.7% of students claim that they have seriously considered attempting suicide during the 12 months before the survey, with 19.4% being female, and also, as I mentioned again, is statistically significant. There was no statistical significance between different grades, so it was fairly even between 15 to 16%, and then that statistical significance is noticeable when it's broken down by race and ethnicity, with Hispanic and Latino students and white students at about 16%. Next slide, please. This, as I mentioned, this has been a question that we've been asked, as you can see in the graph, since 2005. The good news is that we actually haven't seen a change from 2005 to 2023, so it's been fairly stable in terms of the response and the percentage of students who have considered attempting suicide, so not, no dips or even increases. Next slide, please. Then the question that usually follows when we ask about suicide ideation has always been about students who attempted suicide. And the way that it's actually asked in the survey, we ask the times that they have attempted suicide, but for the purpose of this data, we sort of categorize it to yes or no. And it's one or more times during the 12 months before the survey. So about 7.7% of students said that they have attempted suicide, with 9.3% being female, again, statistically significant when compared to their male counterpart. There also was a statistical significance between grade groups. So ninth grade was statistically significant when compared to the 12th grade. So 9.1% of the ninth graders said that they have attempted suicide. And as the grades, as the students get older, that number dips. When we look at the race and ethnicity, you'll notice the black bar. So the black bar is there because the sample size was actually very low, and we're trying to keep the surveys confidential. So we're because of the sample size, we usually black that number out. So it was fairly low for the Asian race and ethnicity group. But you'll notice that Hispanic and Latino are at 10% of students who have attempted suicide, followed by Black students at 7.5 and white at 6.4. And it was, when you compare the Hispanic students versus their Black and white counterpart, it was statistically significant. It definitely warrants something to look into it. This has been a question that's been consistently asked for the past 10 cycles of the survey. But the good news with this is we actually have noticing a decrease. So from 2005 to 2023, we have noticed a steady decrease overall. So I think that's the positive message that we can take from this. Next slide, please. So when I was thinking about youth mental health and like looking at the landscape, I was thinking about other data points and variables that would be useful when we think about this. And I know from literature, we have seen that there has been some significant findings between the more screen time they have and their poor mental health outcomes. So the next slides will follow is just me looking into other data points that I think would be useful for you all to know. So this one is the percentage of high school students who spend 3 or more hours of screen time, and again, it's separated by sex, grade, and race and ethnicity. So about 79.1% of students said that they spent 3 or more hours of screen time. There is actually no statistical significance between all of them, so it's fairly evenly split. It doesn't matter if it's, I apologize, doesn't matter if it's sex, grade, or race and ethnicity. It hovers around 77 to 80%. So there's not much a difference between these subgroups. Next slide, please. And this is a new question. It was just asked for the first time in 2021, which was around 76.7%. It has increased, and it's a statistically significant increase to 79.1% in 2023. We asked this question again in 2025, so I'm very curious to see what the number looks like for this year's survey. Next, please. The other, when I was doing the literature review, is that missed school days also is associated with poor mental health. This is actually, when I was putting this, it's not really a perfect variable or a data point to look at, but I still would be interesting to see it together because it does count days, it does count school suspensions, and it does count if they're sick. So it's not, it really is not a good variable for like poor mental health, but nonetheless, it's interesting. So 69.6% of high school students have missed school one or more days in the past 30 days. And 75.9% of that were female, and it's statistically significant when compared to their male counterpart at 62.8%. There was also a statistical significance when looking at their grade level, with 12th grade being the highest at 75% of missed school days, and the race and ethnicity, Hispanic and Latino students at 72%, and that was statistically significant when compared to their Asian and Black subgroups, with white students also at 70%. So both the highest rate really with this, with missed school days, was seen between Hispanic, Latino, and white students. Next slide, please. This is also a relatively new question, and we actually have seen an increase in school missed school days from 2017 to 2023, and really the biggest increase was seen from 2021 to 2023, where it went from 58.2% to 69.6%. This question, I believe, if I remember correctly, we asked this question again. So my thought process when we created the questionnaire for 2025 is that if I've asked, I'm trying to build a sort of a trend line. So if we have like, we've been asking for the past 3 to 4 cycles, most likely was included in the 2025 survey. Obviously, if it was relevant. Next slide, please. So we'll pause here. Thank you, Kate. I'll take your thoughts. I've seen the comments, so I haven't had a chance to read them all, but I can point out anything, Kate, that you need to. So this survey, it is only for high school students. So usually it's not given to elementary or middle school students. Let me see. The survey was about 3,100 students participated in the 2023 survey. So about 50 schools were selected. Oh yeah, and I saw somebody that responded. So how do you know if the changes in response about their own mental health over time are due to the respondent awareness of their own mental health or increased decrease in their willingness to respond honestly? That is a very good question, and that is the question that we always ask. I think that's one of the limitations of the survey. We can look at the data, but we really can't make much assumptions. So we can tell when, there's the difference is statistically significant, but I think that's up to the professionals and the people in school to really figure that out. But that's a very good question.
Can I highlight a couple questions? So
yes,
earlier in the chat, someone had asked how this information is used by the CDC. Do you have any ideas on what they do with this?
That is actually a very good question. I know that they provide funding to schools for further work. So Connecticut, we just get money from our grant for surveillance money, but there is other states who receive money for implementing programs and new policies and new studies, but Connecticut specifically just for surveillance.
Yeah, that was my thought. They probably use it to help determine programs and grants that they want to offer to different populations. Carrie, so there's some questions about attendance, and I apologize if I missed this. So was that 1 or more days in the last month, in the last 30 days? Okay.
Yes.
So that's interesting to know, because if a student is missing 2 days a month, by the end of the year, they're considered chronically absent. They've missed more than 10% of school days. So that really does add up. Um, and I don't think if you joined us last time, you heard all about this. I don't think students realize that, or parents, that, one day a month or 2 days a month, every month really does cut into that instructional time.
Yeah.
Is there anything similar that exists for elementary age students?
Not that I'm aware of. There is
Mm.
for middle school. So the YRBS can also be given to middle schoolers, but for the state of Connecticut, we have just opted out for the high schoolers. For elementary, I'm not aware.
That's what I thought. And I don't believe this is the schools don't have access to the individual students' results, right? It is anonymous, and I understand that concern too. If there's 15% of students who are seriously considered suicide, my instinct would be to try and figure out who those students are. But due to the anonymity, to make sure that
Confidentiality, yeah.
the confidentiality, and to make sure that the results are valid and not influenced. If a student knows that the school's going to get their name, they might not be as honest. Um,
Correct.
so
We only
yeah,
provide state level data, and I know that we always have schools that reach out to ask, or even health districts that reach out and ask for their specific. But the most granular breakdown that we can give is by rural, suburban, or city. Like we can break it down by that kind of demographic, but not by particular schools.
okay. Just in the interest of time, we'll have some opportunities to reflect as we go on, but we're going to keep moving forward. And please keep putting your questions in the chat.
Yes, thank you. So again, when I was thinking about what affects youth mental health, I also was interested to look at how that looks in terms of alcohol and substance abuse. So I've added a couple of those questions in here so we can look together. Next slide, please. So the question is high school students who currently drink alcohol. So in the parameter is at least one drink of alcohol on at least one day during the 30 days before the survey. So about 21.1% of students reported they currently drink alcohol. And when you break it down by gender, 24.5% female and 17.6% male. Again, that's also statistically significant. I think anecdotally we know, and from what I've read, and please correct me if I'm wrong, but usually female students have worse mental health outcomes overall than compared to male students. The difference is also noticeable in the grade level. So 12th graders had higher percentage of them reporting they currently drink alcohol at 33.7, and followed by 11th graders at 24.2%. Ninth grade and 10th graders were much lower than the 11th and 12th grader. That difference is also noticeable and statistically significant when we break it down by race and ethnicity, with white students reporting 27.4%, followed by Hispanic and Latino students at 17.3%, followed by Asian students at 11.6 and Black students at 8.7. And when you compared Hispanic and white students with Asian and Black, that was statistically significant. So that wasn't a random finding. There's something there in that trend. Next slide, please. This question, again, has been asked very consistently since 2005. We have noticed that we've seen actually a decrease, so that's the great news. And the biggest decrease was actually seen from 2019 to 2021, where it went from 25.9 to 17.5%, and it has stabilized in 2023. Thank you for the pointer. And that decrease was statistically significant. So something happened, and I mean, maybe them being hybrid, not have, because of COVID, not having as much social gathering that could have influenced that, but something definitely to look at. But overall, from 2005 to 2023, the trend has been going down. Next slide, please.
I'm really curious, and I know one of our colleagues, Kelly, is on as well, and she's going to be presenting for us in December. But Kelly, can you throw in the chat? I'm curious when cannabis was legalized, and if that may have had an impact on the percentage of students who are drinking alcohol. So I don't know if Kelly, if you could put that year in the chat. I'm just wondering if that dipped for 2021, the pandemic, but if there are other things that may have been available at that time that students were choosing instead. Yeah. Oh, Kelly believes it was 2021. Interesting. Okay.
So remember this trend because I've actually am including cannabis use as part of the substance use. So remember what it looks for, and we could go back and forth, but that's actually a very good point, and I didn't really think of that. I was associating it with the pandemic. Next slide, please. I also wanted to look at, we asked questions about students who were binge drinking, and we defined binge drinking as 4 or more drinks of alcohol in a row if they were female, and 5 or more drinks of alcohol in a row if they were male, within a couple hours on at least one day during the 30 days before the survey. So 11.6% of students reported they were binge drinking, with 14.1% female and 9.1% male. Again, that's statistically significant. That statistical significance was also seen in the grade breakdown, with 20% in the 12th grade, 14.1% in the 11th grade, 10%, and almost 10% in the 10th grade, and then 4% in the 9th grade. And again, the 12th grade was statistically significant when compared with the other grade levels. You'll notice that with the race and ethnicity, the numbers are very low among Asian and Black students. So they were blacked out because the sample was so low. But we do notice 15.2% among white students who reported they currently were binge drinking, and between Hispanic and Latino students was 9.9%. And that was statistically significant when the two were compared. Next slide, please. This is a relatively new question, so it's been asked since 2017. And the good news is that we actually have seen a decrease. And the biggest decrease was seen again from 2019 to 2021, where it went from 12.9% to 7%. And this decrease was statistically significant. So cannabis use. So there's a question where we ask about students who currently use cannabis, and one or more time, and it has to be 1 or more times during the 30 days before the survey. So 14.4% of students claim that they are currently using marijuana, with 16.1% female and 32% male. And that difference is really noticeable in the different grade levels. So as the older they get, their usage went up, with 12th grader at 21.7%, and it was statistically significant also. When we look at that broken down by race and ethnicity, 60% of students who reported current use were white, 14.9 Hispanic and Latino, and 9.5 Black. And the Asian group the sample size was low, so we had blacked that out, but it was very low, if I remember it correctly. And that was also statistically significant when the white students were compared to Hispanic and Black students in terms of their current use of cannabis. Next slide, please. And I believe this is a trend, so this would be interesting. So we also have seen an overall decrease in cannabis use. And the decrease, you could also even notice it from 2013 to 2023. And then the biggest dip that we have seen was from 2019 to 21, where it went from 21.7% to 11.1%. And it is slightly increased in 2023, but not enough to cause statistical significance for those 2 years. But so my theory, again, with the pandemic was also this, but now I don't know. And I think that's where it comes. People who work in schools can have a little more insight than what I have, because I just have a point in time. Next slide, please. We also look at drug use, and we ask a multitude of drug use questions, and they're all fairly very low, to be completely honest. But the prescription pain medication without the use of prescription pain medication without a doctor's prescription or used differently was something that I'm very interested in. So I thought I would include that with you all. But 12.2% of high school students claim that they took prescription pain medicine without a doctor's prescription, with 13.3% being female and 10.8% being male. Again, that's also statistically significant. So we are noticing a difference between the sex. And the highest group of, actually, we are also noticing a statistical significance in the grade level, with 15.6% of ninth graders reporting that they have taken prescription medicine without a doctor's prescription. And that decreases actually as they get older, and it's statistically significant when compared to the 10th and 11th and 12th graders. In terms of race and ethnicity, Black and Hispanic students are equal in terms of their percentage at 14%, and followed by white students at 9.9, and Asian, the sample was low, so it was redacted. But and it was also statistically significant when you looked at the Black and Hispanic students and compared them to the white students in terms of the responses. Next slide, please. Again, this is a newish question, so it was asked in 2017. There was no change, so it's been fairly consistent from 2017 to 2023. There was a slight dip in 2021, but it was not statistically significant from 2019 to 2021. Next slide, please. The other thing that I thought would be interesting, kind of goes hand in hand sort of with the substance abuse, was if students ever been offered, sold, or given an illegal drug on school property during the 12 months before the survey. So about 9.9% of students claim that they have been offered illegal drug on school property, with the highest, with females being at 10.2% and male at 9.7%. But the good news is there's actually no statistical significance between the sex, so there's really no real difference. But the difference is noticeable in the grade level and in their race and ethnicity. I apologize, getting tongue twisted. With 10th graders being at 12.3%, being the highest, and it was statistically significant when compared to the ninth graders, and ninth, 11th, and 12th graders hovering around 8 and 9%. Hispanic and Latino students reported at 12.2% of them who have ever been offered or sold or given illegal drugs on school property. And then it decreased at 9.1 for white students, 7.6 for Black students, and 6.4 for Asian students. And when the Hispanic students were compared, it was statistically significant. Next slide, please. This question, the overall trend, and I want to pull your attention, the overall trend from 2005 to 2023 has actually decreased, and we really are seeing that decrease from 2017 to 2023. And I want to point your attention from 2019 to 2021, where it went from 19.2% to 7%, and then it stabilized in 2023. So something happened from 2017, because it went from 28.6 to 2019 and then again to 2021. And that's, I don't have the answers for that. I just thought I found it very, very interesting to observe it. Next slide, please. So thank you for this break. So any thoughts, any comments, what you're seeing in schools, I would be very interested to hear. Somebody commented that they saw increases of alcohol use during COVID. So yeah, I'm interested why that changed. And yeah, behavior. So maybe they're not being truthful in answering the question. We do have, yes, we asked actually quite a bit of vaping question. If I remember the survey correctly, that has gone up. And you can find vaping data in our website. So if you just Google Connecticut School Health Survey, it's the first link that pops up, and you can see the full report from 2023. And we ask about, I want to say 10 to 12 questions regarding vaping and other vaping products.
Thank you, Kelly. In our December one, we're going to be diving more into substance use, and Kelly's going to share more about vaping. Yeah, I know that vaping is a huge issue, unfortunately, in schools. I know that from my time in schools. And I just want to be mindful of time, so we're going to keep moving forward. We're about halfway through our presentation today, and we've got a good number of slides to go. So keep sharing the chat.
Yep, and these are quick because I also want to be mindful of time, but we also want to talk a little bit about bullying, because that has an effect on mental health. So if you go to the next slide, Kate. So we asked a question about if they were bullied on school property during the 12th month before the survey, and it's ever. So even one instance counts. So about 18% of students claimed they were bullied on school property, with 20.9% being female and 14.9% being male, and that was statistically significant. When we look at the grade level, ninth graders and 10th graders reported higher rates of them being bullied on school property versus the 11th and the 12th grader, and that was statistically significant as well when you compare the ninth graders with 12th graders. When we look at the race and ethnicity breakdown, 20% of white students reported they were bullied on school property, followed by Hispanic and Latino students at 16.7%, and then 14.5% for Black students and 8.5% for Asian students, and that was also statistically significant. Next slide, please. This says we have asked this question since, oh, can you go back one more? Yeah. So this question has been asked since 2011, and we have noticed a decrease in overall from 2011 to 2023 in terms of students reporting they're being bullied on school property. We really noticed a dip in 2021. Again, I kind of attributed to them being that hybrid schedule, half in school and half at home. And it's sort of stabilized in 2023. So I'll be curious to see what 2025 looks like. Next slide, please. Electronically looking at students, online use, social media. So the next question that we asked is about students if they were electronically bullied. And that could count texting, Instagram, Facebook, other social media ever during the 12-month period before the survey. So 17% of them claimed that they were electronically bullied, with 20.4% being female and 13.2% being male. And that was statistically significant. When we look at the grade breakdown, 18.7% of the ninth graders said that they were electronically bullied, followed by 19.4% of 10th graders were electronically bullied. And as they got older, that decreased. But when we compared the ninth and the 10th graders with the 12th graders, that was statistically significant. So there's something happening there between the ninth and the 12th graders. When we look at that with race and ethnicity, 19.1% of white students claimed that they were electronically bullied, followed by 16.6% of Hispanic and Latino students, and 13.4% by Black students, and Asian, the sample was very low. And it was statistically significant when you compared Hispanic students with Black and white students. Next slide, please. This question, again, has been asked since 2011. It was no change from 2011 to 2019, and then from 2019 to 2023, we actually have noticed an increase in students who reported they were electronically bullied, and the biggest increase was seen from 2021 to 2023. Next slide, please. So I've talked about all these sort of negative, risky behavior, and that it could affect also the youth mental health. So I wanted to end on sort of a positive note because we do keep track of protective and positive childhood experience. So I wanted to end with that. So if you could go to the next slide. Okay, because I think it makes a difference if students feel that family connectiveness or school connectiveness. So the question that we ask in terms of the protective factor is if they strongly agree that their family loves them and gives them help and support when they need it. And about 85.6% of students said that they do feel that. And 89.6% were male and 82% were female, and that is statistically significant. What I've seen is actually, and you'll notice, but in terms of protective factor, we find that the male counterparts actually have more than female. So that was interesting and something to look at. It wasn't with just this question, but there was no real difference. Well, actually, there was difference between the ninth and the 12th graders, with 12th graders having higher percentage of them feeling loved and supported when they needed, with 87.5%, and ninth graders at 83.8%. That difference was also seen among the different races and ethnicity, with white students at 88.1% and Asian student at 86.8%. And when you compared white student, the difference in rates with Black and Hispanic student, that was statistically significant. Next slide, please. So this question has been asked since 2007 and really hasn't been any change. So it's been fairly stable, hovering around 84 to 86% every given cycle. Next slide. And I believe this is the last one where we look at the percentage of high school students who most of the time are always feel that are able to talk to an adult in their family or another caring adult about their feelings. So about 49% of students said that they have that support, with 51.4% being male and 47.1% being female, and that's statistically significant. There was no statistical significance in terms of grade levels, so it was fairly equal around the 49 to 50%. I know that the 11th graders was at 45%, but there was really no statistical significance when compared to the other grade level. But you do notice statistical significance when you look at the race and ethnicity, with 58.7% of white students claiming that they have someone that they can talk to about their feelings, and then that drops considerably if you look at the other race and ethnicity, with Asians being at 37%, Black students at 41.6, and Hispanic and Latino at 38.8, and this is statistically significant. So something to look at. Next slide, please. And this is a new question, so I'm curious to see. There's not much. We know that there's an increase from 21 to 23, and it's statistically significant, but I can't tell you more beyond that. More data would need to be observed. And I think this is the last one, I believe. Yes. Yep. So
Thank
I'm
you
getting
so
some really
much.
good comments. Yeah, thank you, Kate.
Yeah, thank you so much. And this is sort of wrapping up Adora's piece on the Connecticut Youth Health Survey. So any questions you have or comments, please feel free to share those in the chat. I see some folks agreeing with what I had put in there. You know, it's, on one hand, it's great that, 48% of students have someone they feel they can talk to about their feelings, but then that also means half of our kids don't, which is sad. And I also think it's interesting that what we perceive, like we might think that we are a caring adult that a child could talk to, but their perception might not be that. So it's interesting, I think. Yeah. Well, that's an interesting point Brett made, that students who may not have an IEP or a 504 don't get access to that support as much in school. They don't have that, maybe that personal connection with someone, whether it's the counselor or school social worker that they feel they can talk to. Yeah, Stephanie shared that isolation and feeling alone without someone to turn to seems to be increasing. And I think that goes sort of hand in hand with that our students are living their lives virtually more so. That can lead to that social isolation. So if anyone has any, the word trust changes the results. Oh, that's interesting.
I will make a note of that.
Yeah, that's an interesting point, that trust is so ChatGPT as a therapist, that's a whole other can of worms that I'm hoping to have a webinar on in the future. The AI is concerning in that area. But again, in the interest of time, I'm going to move us along to Stephanie, and we'll keep moving. Again, please keep sharing in the chat, and we'll have some time at the end to ask questions overall as well.
Thank you. So as Kate mentioned in the beginning, I am from the Department of Children and Families, and what a lot of people don't realize is that the Department of Children and Families actually holds the behavioral health mandate for children. So we share a lot of work with the Department of Mental Health and Addiction Services, and we've been hearing from Kelly, who will be in a future presentation talking about substance use. So today I'm going to be talking a little bit about our mental health services, specifically our crisis services. So most people, like I said, when they think of the Department of Children and Family, or DCF, they really think of like the Child Protective Services. Next slide. But what often people don't realize is that we also administer and have oversight over the children's behavioral health. And I sit in the division where we oversee our children's mental health. And what we've done here in Connecticut is we've aligned our crisis continuum with national best practices from SAMHSA, the Substance Abuse Mental Health Administration at the federal level. And what they have said is that to have a really robust crisis system is to have someone to contact, someone to respond, and a safe place to go for help. So here in Connecticut, we have someone to contact, which is 988. Hopefully all of you are familiar. If you want to throw in the chat and just let me know if you are familiar, that would be great. There was legislation passed a few years ago that actually asked that student IDs have 988 written on the back of their IDs. So hopefully students are familiar, but I'll be talking a little bit about what that is. Next slide. So in Connecticut, the 988 is actually a national number. And in Connecticut, we utilize United Way as our call center. And our call center also receives calls through 211, which was our mobile crisis line, and they also receive calls for the adult action line. So we have a one center that answers all of the phones, but 988 is the suicide and crisis lifeline number. We're trying to make it really easy. Before it was like a 1-800 number, and so several years ago it changed to 988 to really help with ease and access. The support is available 24 hours a day, 7 days a week, 365 days a year, and anyone can call because it is a self-identified crisis. So it doesn't need to be like a significant crisis. If somebody is struggling and they need someone to talk to, they can talk to 988. They also do chat and text services, and again, that is all through United Way. There is a national backup center, so if for some reason someone within Connecticut can't answer within a certain time period, it does roll over, so those phone calls and chats and texts will all get answered. The call center and the chat and text, what they will do is they'll do a mental health screening, suicide risk assessment, all based on national best practices, and then they'll work with whoever is calling or contacting them to assess the situation and make sure that they're connected to the right level of support, whether that's collaborative safety planning, whether it's follow-up contacts, whether it's a WARM transfer to adult or youth mobile crisis, which I'll talk about next, or even, if necessary, emergency safety services as well. Next slide. So the next, after you have someone to contact, you need someone to respond, right? So if something different is needed, if it's more than just a call, if somebody needs to show up, and hopefully folks are also familiar with mobile crisis, but mobile crisis is where a clinician or support can go to where you are or where the family or the child is needing support. So it can also be called from schools, so they'll respond to schools. So it's designed to be really highly mobile and go wherever the youth is. It is designed to be responsive with a goal of arriving within 45 minutes or less, no matter where you are in the state of Connecticut. So the Department of Children and Families, we contract with several different agencies so that they can respond anywhere in Connecticut with the goal of getting there 45 minutes or less from the time that you call and say that you need mobile crisis. It's available 24 hours a day, 7 days a week, 365 days a year. And again, it's supposed to be able to meet the needs of whoever is calling. They're responsive to schools, emergency departments, the police, families, and whoever is calling that needs that support. They are really, the goal is to address the crisis and be able to divert from needing higher levels of care. Next slide. So some data related to last year, so this was July 1st, 2024 through June 30th of 2025, Mobile Crisis had over 11,000 episodes of care, meaning that there were 11,608 calls that came in, and it served 8,428 children. So that could mean that a number of those youth, maybe the families called several times or something like that. They had a 95.8 mobility rate and responded to 88% of the mobile episodes in under 45 minutes. Again, that goal is to make it out there under that 45 minutes. 42% of the callers were schools and 40% were family or the child themselves. Oftentimes what we say to schools is if you know a youth and they're starting to escalate in their behavior, you can call at that time and say, you know what, we know that this is going to end up in a crisis and we really would like that support. And they can start that crisis de-escalation and get there before it escalates into something that's unmanageable. Children who were most commonly presenting to mobile crisis were presenting with harm or risk of harm to themselves at 30%, and then disruptive behavior at 26%. And that's actually interesting because in the past that was actually flipped. So we used to see a lot more calls for disruptive behavior, but in the recent years the trend has sort of flipped and we've actually seen more risk of harm to self. 39% of children received ongoing stabilization services. So what that means is after the call and after somebody from Mobile Crisis arrives and they're meeting with the child, they can keep that case open. So it's not just a one and done. They'll keep that case open, check in with the family, check in with the child, double check that the safety plan is working or not working, tweak it if needed, and really work with that family until the next level of services are in place. And 41% of children were referred to outpatient services, and 36% already were seeing somebody and had a provider, so they were referred back to that existing provider. And then 29% were referred to multiple services. So maybe there were multiple needs that they needed, and they were referred to several different types of services. Next. So this is just a quick map for folks to see sort of we are statewide, as I mentioned, and the little yellow dots are where the providers are located. Again, we've tried to make it so that they're able to access wherever the state needs within that 45 minutes. And you can see the episodes per children, so you can kind of see like a heat map. Next slide. So some of the demographics, who is being served, you can see the Connecticut population and the mobile crisis population for comparison. It doesn't match completely, and part of that is because of where the mobile crisis location is. So if we broke it down by where they are actually serving that community, it does match up a little bit better, but this is the whole state compared to the mobile crisis population. You can also see that we are serving the race and ethnicity and the sex and the age breakdown there. You can see that most of the calls are between the ages of 9 and 15, with the largest age group being between 13 and 15. Next. Then we have somewhere safe to go. So the goals, and this is a fairly new service, urgent crisis centers were created and started about 2 years ago now. And the urgent crisis centers really aim to provide a safe place to go. Not everyone wants somebody coming into their home, and so this offers families another opportunity to have their behavioral health needs met. We know that emergency departments aren't necessarily the best place for a child with a mental health crisis, because there's always lots of things that are happening. They may not be seen for a long time. And so urgent crisis centers can almost be thought of like an urgent care center. Like you don't need an emergency department or a hospital for like a sprained ankle. This is very similar in that way, where you don't need to go to the emergency department, but this is a center specifically for behavioral health needs. When a youth and family arrives, they will triage the family and really determine what the next steps are needing to be. They'll provide de-escalation and crisis stabilization, develop crisis safety plans collaboratively with the family, and then provide that continuity or bridging services until the next service is available. They can also coordinate with mobile crisis to ensure that any sort of service needs are being met until that next level of care is available to them. Again, the goal is also to reduce the inappropriate use of more restrictive services. So really ensuring that we're meeting the needs, de-escalating the crisis, and trying to get them back into the community whenever possible. Next slide. So key findings, again, this was from last fiscal year, so July 1, 2024 through June 30th. The urgent crisis centers, we have 3 community centers throughout the state of Connecticut, and you don't have to be in that area. So there's one in Hartford, and you happen to be visiting something in Hartford, they can go to the one in Hartford, even if you live in Waterbury. There's also one in Waterbury, and then one in Norwich, or New London, I'm sorry. So you can go to any of those. And then there is one in New Haven, which is hospital-based. So this data is actually from the 3 community-based urgent crisis centers. And those 3 community-based urgent crisis centers served 1,328 children. 88% of those children showed improvement from when they showed up to the time that they discharged, and that was per family report. 47.8% of the families said that they were referred to UCCs by schools, so that's where they had heard about the urgent crisis centers. And most commonly presenting is very similar to mobile crisis, except a higher rate of harm or risk to self and 22% disruptive behavior. 51% of the families reported that they would have gone to the emergency room if a UCC wasn't an option. So again, knowing that emergency departments aren't the best place for behavioral health crisis, this was a really important question that we asked families because many said that they would have gone to the emergency room, and many also said they wouldn't know where to go. And then 97.6% of children were discharged back to their homes and communities, which is what we wanted to see. Next slide. So this is some of the demographics around who is being served. We do have a slightly higher percentage of females that are being served at the community centers. We had 44, so this is not matching up exactly to the Connecticut population, but again, this is a very new service and we only have 3 in the state. Next. This is a heat map. The little yellow dots, again, are where they are located, and then you can see kind of where they're coming from. Next slide. And this is just a quick comparison, and you all have this so you can reference it, sort of the differences between mobile crisis and urgent crisis. But really what we wanted is to have a choice, right? Again, like I mentioned, not everyone wants people to come into their home. And so having both mobile crisis and urgent crisis centers gives families and children the ability to sort of choose which service and what they're most comfortable with. Again, safety is always the goal. And so if it's not necessarily safe to bring a child to an urgent crisis center, mobile crisis can also address and go to a family. And I see a lot of questions, and I apologize, I have not caught up with that. So I'm going to scroll real quick and try to see if I can answer some of the questions that have come through.
I can summarize because there's been some common themes.
Great.
One of them was about 211's hesitancy or reluctance to come out to do an assessment without permission. Can you speak a little bit about that?
Yeah, so that has been a conversation that we've had a lot. And so in order for a mobile crisis to actually assess a child, they do need parental permission. However, if parental permission has not been gathered, they can still help support the school. And so that is something that we are trying to address. Again, we do need that permission to assess the child directly and provide direct services to a child. However, they could help support the adults in the classroom. They can help support kind of how to manage the situation and those types of things. And so if there has not been received, you can continue to try to receive that and still have mobile crisis come out.
Another common question was families not getting the follow-up that they expected from mobile crisis, connection to services afterwards. How would you recommend that folks deal with that?
Yeah, so that I would need to know a little bit more if it's the mobile crisis follow-up or if it's like the wait list and lack of sort of available resources as the follow-up. We've heard from a lot of providers that families are experiencing really long wait lists because our workforce is, having a shortage in terms of mental health care and things like that. So I know outpatient clinics are really inundated. So I'm not sure if this question is related to the service or if it's mobile crisis that isn't following up. But I think, one of what I would recommend is if that ever does happen, feel free to reach out to the mobile crisis team in your area to just kind of problem solve and let them know that that's an issue, because I think that it's helpful for them to know what's happening at a local level so that they can address it if there are problems.
So would you recommend, and I can put this in the chat, that instead of going through the 211 process, if they do have questions about that follow-up, to contact the agency providing the mobile crisis services directly?
Exactly.
Okay,
exactly.
I'll put that in the chat. Something else that's come up is about the UCCs. We wish we had more. Unfortunately, that comes down to a funding question. So yeah, but the more they're used, the stronger the argument is that we need more in the state.
Yeah.
And I'm going to, yeah, sorry, go
So
ahead.
I do also want to address a couple questions related to 211. 211 also receives, it's also info line. And so when somebody is calling, they could end up at the wrong line. So there's info line, which you access by 211, but then there's also mobile crisis. Um, 211. So when somebody calls, they need to make sure that they're following the prompts to ensure that they're getting into the right line. So there's 211, which is info line. Once you get through that, if you want to access mobile crisis, they would need to dial 1, then 1. The other way to access mobile crisis is they could also call 988 and get through that way as well. In terms of insurance, you don't need insurance for mobile crisis or 211 988. For UCCs, they do take insurance, but if you don't have insurance, they are not going to turn you away.
Thank you. Just in the interest of time, we've got about 15 minutes left, and we do have some exciting information about the Connecticut Clearinghouse. We went through a lot of different topics today, from substance use to suicidality, and the Connecticut Clearinghouse has a wealth of information and free resources to sort of address a lot of these concerns. So I'm going to hand it over to Angela.
Hello. As Kate just said, my name is Angela. I'm a prevention specialist at Connecticut Clearinghouse. And I'm really excited to tell you about some of our resources and services. I don't think we'll have time to do a tour of the website, but I can also, I'll drop my contact information in the chat and then we can get in contact and I can give you a tour via Teams. The Connecticut Clearinghouse is a statewide library and resource center funded primarily by the Department of Mental Health and Addiction Services. We offer information and resources on substance use prevention, mental health promotion, and a wide range of related topics that include parenting, bullying prevention, grief and loss, and just a lot more really good stuff. And our resources are like can reach people across the lifespan. So we have stuff for little kids and we have stuff for older adults. Next slide, please. Just a little background on who we are and where we came from. Connecticut Clearinghouse was established in 1988 as an educational resource to correct a lot of misinformation, misguided campaigns, and a lack of evidence-based information. Next slide, please. Our resources and services include library materials, which can be borrowed, such as books, curricula, DVDs, if you still have a DVD player, and materials that can be accessed online, such as ebooks and psych therapy videos. Our membership is free, and that's available on our website. We disseminate our pamphlets, posters, and fact sheets across the state. They're available in person or via our online order form. We offer free training opportunities in a prevention listserv that includes our newsletter, toolkits, and events offered by our partners in prevention and treatment. We also have the Change the Script resource vans, Gloria and Declan, for outreach and education. Next slide, please. Here's just an example of some of our titles. Our most popular titles are evidence-based resources, which reach children across the state of Connecticut. So we have Holden Pot, the ACT workbook for kids, and these are just some of our materials. You really got to come in and visit us. Next slide, please. We have evidence-based curricula as well, and we also have educational flip charts, which are very popular, board games, and more items to help educators, prevention specialists, and others really help interact with youth and teach them about prevention and healthy habits. Next slide, please. Our librarian, who couldn't be here today, she strives to ensure the resources are not only relevant and well-reviewed, but also vetted by professionals and others whenever possible and written by experts in their given field. I do see a question. Yes, some of our resources are in multiple languages. I know we have some Spanish books, and we're also have recently purchased a bunch of books in Polish as well. Next slide, please. Patrons can access our materials in a number of ways, including in person at our library. Mail, interlibrary loans is if you can't make it out here, your local library, if we have a book that you want, they can help get it to you and we can send it to them. Via our library catalog, which is also on our website. And we just got a new one, so we're really excited about it. Next slide, please. While the best way to view the pamphlet collection is in person, we have copies of them so you can look through them. We realize it's not always possible. We do have a pamphlet and poster directory and an online order form. Fact sheets can be downloaded and reproduced as they're all in the public domain. And the directories have been updated, so now it's a lot more user-friendly to find what you're looking for. Next slide, please. Our prevention listserv, and as I mentioned in an earlier slide, this gives you an idea of just kind of things we send out across the state. They can include trainings, many of which are free, community events, and more, in addition to our own newsletter and toolkits, which really just highlights new materials and anything that people might, usually in health observances for the month. So last month, our toolkit was suicide prevention. Thank you, Kelly, for dropping our link. We try to send out a limit of 2 emails per day just to not fill up your inbox. I lost my place. I'm so sorry. If you don't want to receive all those emails, you can also sign up to just receive the newsletter, which is 1 email a month. Thank you, Marissa. I believe the workbooks, we have a variety of them across the lives for various ages. So I think it would really depend on specific workbooks that you're looking for. Next slide, please. Our events, you can register for free and educational self-care events, some of which are virtual and some are in person. On November 19th, we have a Reiki Wellness Wednesday. The Wellness Wednesdays aren't for continuing education credits. Those are more just self-care and just meant to be a fun thing. This afternoon, we have our survivor-centered and trauma-informed domestic violence webinar. If you want to join, it's not too late. I would love to see you guys there. But yeah, the QR code should be right now, but also you can go to ctclearinghouse.org/registration and see a list of all of our upcoming trainings. Next slide, please. You might also see us around the state. We like to bring our resources to you, whether it's through our van outreach, conferences, or community events. You may also even see our mascot, Starfish Stella, who's up in the corner over there. Next slide, please. National Prevention Week. Stella the Starfish was developed during planning for National Prevention Week, which happens every May. The 2025 statewide event was a big hit at Danbury Fair this year. And in 2026, National Prevention Week will be from May 10th to May 16th. We're in the early planning stages, but please stay tuned for more news. And if you're interested, please get in touch with us and we can connect you with more information about NPW. Next slide, please. Change the script. The Change the Script vans can visit your community or school. In addition to educational resources and medication disposal bags, staff are available to provide a brief naloxone training and provide naloxone to training participants. You can check their schedule and book online at drugfreect.org. Next slide, please. I also wanted to mention a partner initiative, Youth Recovery CT, which aims to empower and inform Connecticut youth and young adults, and family on their recovery journeys. This initiative is funded by DCF and DEMIS. Youth Recovery CT coordinates a grantee network comprised of behavioral health agencies, schools, colleges, and the Department of Corrections, and community organizations that host peer recovery meetings and sober social activities throughout the state. Next slide, please. I hope I'm pronouncing this right, Mara. The ebooks, you would need a membership, and there's a login. When you get the membership, we send you your login information to access the ebooks. With the Youth Recovery CT also uses the SMART recovery model, which integrates evidence-based approaches from REBT, CBT, and motivational interviewing. If you're interested in learning more about SMART recovery and all that, please get in touch with my colleague Laura Zeppieri. Her email and the Youth Recovery CT website are right there. Next slide, please. I also want to mention that a few of our staff at Connecticut Clearinghouse are trainers for mental health first aid, youth mental health first aid, QPR, assist, and a lot more really good stuff. If you'd like to train staff or are interested in any upcoming trainings, you can contact me directly. I have put my email in the chat, or email info@ctclearinghouse.org, and that will just go to Clearinghouse as a whole. Next slide, please. Thank you so much. Please reach out if you have any questions. Follow us on our social medias. We're on all of them. Um, and I don't think we have time to go over the website, but you're welcome to email me with that email or info@CT Clearinghouse, and we can set up a video call and I can walk you through the website. Or you could come visit us in person, which we would really love. But that's it for me. Thank you so much for your time.
I have a quick question. Do you need to schedule an appointment to visit, or you can just show up and you welcome everyone with open arms?
We welcome everyone with open arms. We're open to the public. You can just show up, preferably when we're open, because then we'll be there to say hi. We're open 8:30 to 5 Monday through Friday. I do see a question. Most of our trainings do offer continuing education credits with the Connecticut Certification Board, and we usually specify on our flyers if it's eligible for continuing education.
All right, so this does bring us to the end of our presentation. If anyone has overall questions or something burning question that you threw in the chat, but it got lost in the shuffle, please feel free to drop that in. I see a question about the the PowerPoint. PPT, wow, my brain. I shared that via email earlier. If you scroll up in the chat, I also put a link to access that online. And I will be sending that out again once it is the accessible version. But if you can't find it, feel free to send me an email. Here's all of our contact information here if you have other questions. And as we're sort of answering and asking questions, here are some important QR codes for you all. The first one is Strengthening School Climate to Support Student Wellness. That is our November 20th Student Support Series webinar. My colleague Amanda Pickett will be sharing her expertise. You may have seen her popping up in the chat. She's a wonderful resource for all things school climate and wellness. The middle there in the orange is our course evaluation. That does give you the opportunity to provide some feedback about what you would like to see trainings on or webinars on or questions you have or concerns that you're seeing pop up at your school that maybe we can address through future offerings. And then the last one is the continuing education credit request form. Again, please fill that out by October 31st. So then I can do the automated process to get that information to you all. If you miss that deadline, you forget, send me an email and I will be able to send you the form. But again, that might take time, just depending on my availability to do so. Yeah, just again, a couple questions left, or excuse me, a couple minutes left. Can scroll up in the chat to see if there's any questions that folks have not had answered. And oh, Stephanie, were you able to put in the chat the link to the different mobile crisis providers?
I can, Shirley. Sorry about that.
Oh, no worries.
The same. I did put it in the chat a link to where everyone can find reports. It's in that same website, but I'll put the specific link now.
Okay, perfect. So that's a great opportunity. Instead of going through the 211, if you want to reach out directly to your town or your district's specific mobile crisis provider, that can help make those connections and answer some questions, because again, different agencies cover different areas and they might have slightly different ways of doing things. So it's on the chat. LMFT is a licensed marriage and family therapist. So the NSW Connecticut does endorse for LMFTs. It looks like we've got, wow, look at us finishing on time. I am proud of us. You can have 3 minutes of your day back. Please feel free to reach out. You should have all of our contact information is in this PowerPoint. Once I stop talking, I will find the link again to put in the chat to access that PowerPoint online through Adobe. This is not the accessible slides. That is quite the process, so that won't be available until later. And please join us in November.